So, ladies and gentlemen, mesdames, messieurs, bonsoir, good evening. So thank you for joining us today for the webinar. So this is Andre Lee from JL Biomedical. So today our topic will be focused on the hemoperfusion therapy in the AKI and the COVID-19. So it is an honor to invite our speakers, Dr. Alexander Kirsten from Germany, who is the head of the cardiology and pulmonary ICU in the University Hospital Aachen. Dr. Kirsten is the head of the internal quality management program and also the head of the section of the extracorporeal support therapy and the consultant for the cardiology and the critical care of ECMO team Aachen. So in this meeting, Dr. Kirsten will share the experience of applying hemoperfusion therapy for the critical disease in ICU. So at the same time, I would like to introduce Professor Omar from the nephrology and the dialysis department in Abyssinia Military Hospital in Marrakesh, Morocco. And he is the clinical researcher and health economy consultant of the Hemoco-Economic. So Professor Omar and his team has established recent year many publications in the Lancet blood purification and NDT about management of the AKI and COVID patients. So today, Professor Omar, thank you so much for helping us to organize this webinar and invited many professors from Morocco. Thank you. So Professor Omar.
Thank you, Mr. Andre, for this kind introduction. And thank you, Professor Alexander, for accepting the invitation to tell us about your great experience in the management of AKI, sepsis, and COVID-19 patients in intensive care units. It's an honor of us to hear from your experience. And we have decided to invite some great Moroccan KOL involved in the management of AKI in intensive care units, nephrologists, and also intensive care unit managers. So with us, and ladies first, we have Professor Fatim Zahra Jabran, Professor of Nephrology in the University Hospital of Sheikh Khalifa. She has been involved in the management of COVID-19 patients with sepsis and with AKI during the last year. So it's a pleasure for us to have this kind professor with us. Also, we have Professor Naufel Mtiwi from the University Hospital of Casablanca, the most important university hospital in Morocco. Also, Professor Mtiwi was involved in the management of AKI in intensive care units and in the management of hemodialysis patients with AKI. He has been responsible of the unit of the management of the hemodialysis patients that were COVID-19 positive. Also, we are waiting for Professor Shafiq Kattani from the head of the Department of Anesthesiology and Intensive Care Unit in Sheikh Khalifa Hospital, and Professor Ghassan Al-Adib, head of the Department of Intensive Care Unit from the Marrakesh University Hospital. So, ladies and gentlemen, we have the pleasure to hear from the experience of Professor Alexander. Thank you.
Thank you very much. I will start sharing my screen. And let's see. There we go. And share this screen. There we go. And now I hope you see my slides. Well, thank you for the kind invitation and the nice introduction. I'm from Germany, Aachen. We are just at the border of Belgium, Netherlands, and Germany. It's 6 p.m. right here right now. It's very warm. And I'm going to talk a bit about absorption therapy and cover basically everything you just mentioned already: sepsis, AKI, ARDS, COVID-19. And then we can have a discussion about this. These are my conflicts of interest. They don't have any relevance to what I'm going to talk about tonight. And just to start, why are we actually talking about this? We're talking about this because of sepsis. You know, if there were no sepsis, we would not be talking about hemoperfusion therapies. And sepsis being the dysregulated host response, as we define in the sepsis 3 definition, this actually emphasizes that we should maybe do something to regulate the host response. So it's a very nice introduction into why we're talking about these therapies, and it's much better from point of understanding and the old definition of SIRS and organ dysfunction, and then you get severe sepsis and you have collapse in cardiovascular function and you get stroke. No, it's actually infection going bad, bad meaning DAMs and PAMs, cytokine release storm, and then you become septic, and then you have the subgroup of patients who are actually more sick, who have microvascular dysfunction, and those are the ones in septic shock. So sepsis, the life-threatening organ dysfunction due to a dysregulated host response to an infection. And this is what we're talking about, what we would like to do if we're talking about immunoreaction and modulating immunoreaction. That's everything we're actually talking about, whether it's sepsis, whether it's COVID, we are modulating our immunoreaction in sepsis. And you all know this. We are talking about SIRS in this case. You can still use that wording because you had early multi-organ dysfunction due to a severe inflammatory storm. And however, in the end, you end up having patients also who have this post-infectious immune status that is downregulated. And those are maybe the ones with secondary infections and later multi-organ dysfunction. And the therapies we're talking about are the ones that are supposed to provide homeostasis to your immune reaction, with one thought being that maybe your neutrophil clearance of your pathogenic host is much better if you have a kind of serum where post or pre and anti-inflammatory cytokines are in homeostasis. And we know this for ages, and the endotoxins of DAMs or PAMs and sepsis, and we know their mechanisms, and we've looked at a lot of therapies, and none really has broken through, even though we are quite aware of the pathway, you know, the endotoxin pathway with TLR4, with NF-kappa B, and the downstream cytokines that we're trying to modulate. And all the theories we have tried upstream have so far not worked, and we're talking about downstream regulation after the infection. And if we talk about this, it's not just important to understand the pathogenetic mechanism, it's also important to understand what patients we're talking about. Because you're going to have, maybe if you look at it in a threefold way, you're going to have patients who are so little sick that they are very well responding to your primary therapy. And these are maybe too well to need any additional therapy because, you know, they'll get better anyways, and you might do harm. And then you have on the severity scale up here, you might have patients who are so fulminantly ill, or you're being treated too late, that you're doing futile treatment no matter what you do. And you want the patients here in the middle. You don't want those that die anyways. You don't want those that get better and no matter what you do. You want the ones that are kind of in the imbalance in the middle. And it's really hard to find these patients. And finding these patients is one of the focus of what we're doing. And finding these patients has been one of the problems, I think, of previous trials and studies. Starting with maybe the Euphrates trial. You know, you're looking for patients here that are included if they were in septic shock and multi-organ dysfunction score of more than 9, and they actually did endotoxin activity assays. Very well done trial, Dillinger and Antonelli, very smart people, published in 2018. You know, screening about 1,000 patients, coming up with 244 who are randomized to sham or polymyxin B. endotoxin removal. And you all know the trial, it was futile. Mortality was not different, even though the rate of incidence of mortality was high. You know, talking about 32 to 37% of people dying. And you had some patients who were very high, not measurable endotoxin activity. Maybe those are futile, maybe those are too sick. And maybe you have some where the endotoxin activity was low, and those are the ones that might not have needed the therapy. Because if you do a per protocol analysis, if you get into the middle of the endotoxin activity assay between 0.6 and 0.0, you actually get a relative risk reduction in mortality by 42%, and that was statistically significant. So identifying the patients that benefit from your endotoxin or cytokine removal is the essential key, and I think the trial here was negative because they did not identify the patients that were benefiting correctly. This is the problem. You maybe know these trials from Cytosorb, also a provider of cytokine removal therapies. They looked in a first trial in severe sepsis, acute lung injury at 18 treatment patients versus 25 controls. It was safety and IL-6 reduction as endpoints. There were no relevant changes in hematology. It's kind of more of a problem or a safety measure. There was a moderate reduction in platelets and albumin, and the hemoperfusion actually decreased stuff you might want to decrease. There was no signal on mortality, but it's a very small treatment. The larger trial then that came out of the people looking at Cytosorb cytokine removal, and the mechanism is different, but it's a very widely used product. The second treatment actually was a bit bigger, still not large. We're talking about 48 treatments versus 52 controls. Those are very sick people. They're on ventilators, they're severe sepsis or septic shock, they have acute lung injury or ARDS. They had their diagnosis established within 72 hours before trial inclusion, so you're trying to get them early. And they got a treatment of cytokine absorption for 6 hours up to 7 days, alone or in combination with CRT. And the endpoints were normalized IL-6 and a bunch of other secondary endpoints. And if you look at that, that's a very well done trial. It has a couple of problems. 2008 to June 2011. We screened 580 patients over more than 3 years. We end up with 100 patients that we can use. That is a slow recruiting trial. And those are not your everyday septic patients. So I'm seriously doubting generalizability of this data. And if you have IL-6 removal as an primary endpoint, it's not met in this trial. And that is surprising. You hook up a device where you show it removes IL-6, and there's no difference to your control. So what does that mean? Well, maybe it means IL-6 was actually not high enough, so it needed removal. Or it means you have a kind of a balance shift between tissue IL-6 and serum IL-6. However, if you end up with the same curves for treating and control, something is wrong in your population because these devices actually work. We know that. And the IL-6 levels here were moderately high. There's a kind of a spread here, but they're below 1,000. Most patients start at around 500, so that they're sick. However, nobody knows if an IL-6 of 500 is actually something you need to remove for up to 7 days. And I would say the problem with this trial is IL-6 overall quite low. There's a widespread per blood pass for IL-6 removal between 5 and 18%. You actually have unadjusted higher mortality in the treatment group. That's always a bit worrisome. However, you have higher rates of renal replacement therapy in the treatment group. So I think that trial is not really convincing. But despite the trial, and those are the only randomized trial in septic patients for this technology, it's widely used in Europe and North America. Even though the data actually does not justify overall use for every patient in sepsis. Looking at Jeffron data, you have data on the HA330, and that's a Chinese trial published, also small cohort, 25 versus 21 controls, acute lung injury, actually induced by extrapulmonary sepsis, so a bit more of a homogenized group because they all had like intestinal sepsis. They had development of organ dysfunction requiring ICU admission, and then they looked at a lot of things, cytokines in the lavage, Apache scores, TPDD measurements, PF ratios, mechanical ventilation, and so forth. And that is an interesting trial because despite the small group of patients, these are very sick patients, SOPA score of 8, Apache 2 score of 26, a typical group of patients you actually find on each and every ICU. And despite the small group, they actually show that the therapy works. Interleukins drop in your bronchoalveolar lavage, IL-1, TNF-alpha, plasma IL-1 drops, plasma TNF-alpha drops. So they show that it actually works from a pathophysiological perspective. You remove the stuff you don't want to have, and the levels are, are sufficiently high. These are sick patients. And you end up, and that's surprising, with very statistically significant differences between control and treatment. So ventilation goes down, duration of CRT goes down, length of ICU stay goes down, and these all reach statistic significance. That is possible, however, it might also be a reason, have a small trial with very big differences. That always makes you worry about bias in treating and selecting patients. And that is a point you have to make about this trial. It's convincing because they measure good things and they show that it works, but it's a small sample. There's very significant differences in all markers. I would question bias here. And that's the reason why you need larger trials, observational and randomized. Those are desperately needed. And we did one step, and that's where we started a couple of years ago. We were starting to do hemoperfusion basically as a rescue therapy. We were worried that we could not identify the correct patients, so we would just use this therapy as the therapy for the ones that were the sickest. And sickest meaning these were patients who were had very high degrees of organ dysfunction. They were in multi-organ failure. They had high IL-6 levels, more than 1,000, and we get those measured here quickly. And they did not respond well to previous treatment for the last couple of hours, meaning they did not show lactose clearance, they did not show improvement in hemodynamics, or they were on a progressive decline. We then did rescue therapy with one set of 8-hour absorption treatment, and we measured things every 2 hours. How did we hook up the patients? Those were all patients that were either on ECMO or on CRRT already. So if a patient went on ECMO, we just hook it up parallel to the ECMO circuit. With that, you actually don't need extra heparin because the patients are already on heparin, have usually ACTs over 170 seconds or something like that. You get blood flows. We measured that in a couple of patients between 400 to 600 ml per minute, so high blood flows. If your ECMO runs around 4 to 6 liters, around 10%, because these lines here are, of course, much smaller than your ECMO lines. And if the patients were on CRT, we hooked up the HA380 like this in line with the CRT. We don't use heparin in this setting because our standard is regional citrate anticoagulation in CRT, and we have a minimum blood flow of 150 ml if we have some kind of cytokine hemoperfusion adsorber, because the standard for the machines we use from Fresenius here would be 100 ml in their standard setting for the multifiltrate pro, and we just ramped that up to 150. And that's fairly easy. That works with basically any dialysis machine. We've tried it with Brown. We've tried it with Gambro. That's just easy to hook up. And this is what we found in this initial, basically a pilot trial, so to speak. Those are the 15 patients we evaluated. And they are very, 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 very sick. They're all acidotic, between 7 and 7.3. They have high lactate, that's millimole per liters, and it's between 16 and I think the minimum is somewhere around close to 5. Very sick. They have high PCT. They have high soluble IL-2. They have high IL-6. And remembering that in the cytokine trial for Cytoabsorb, the mean IL-6 level was around 500. Here we have 11,000, 1,800, 200,000, 4,000, 5,000, 10,000. So high, at least 4-digit numbers for IL-6. And this is probably what we're thinking about if we talk about cytokine storm. They have high IL-8, IL-10, TNF-alpha. They have high values for LPS binding protein, and they are huge doses of vasopressors. That's milligram per hour, so they are on large doses of vasopressors. And what do we find in this pilot trial that we did? We actually find a trend for lactate clearance, and this is a logarithmic scale, so don't get confused. And some of these patients actually drop tenfold within 10 hours. And you see some of them don't, and those are the ones that definitely end up dying. And some of them stay flat or have smaller log changes, but some actually drop. Remember, we treated for 8 hours, so the drop continues after 8 hours, even though the device is no longer hooked up to the patient. Same goes for norepinephrine doses. Most patients go down, again, logarithmic scale. We have large decreases in markers of shock, and that's what you want. You don't, in this situation, you're not thinking about 30-day mortality, you're thinking of markers of shock. You want improvement hour by hour, and you're not talking about 30-day mortality. And looking at the markers we measured, SIL2, for example, small changes, no clear signal. IL-6, strong signals. Again, logarithmic scale, and patients usually drop by more than half after initiating. Some stay flat and drop slowly. Remember that one of the goals is, even if you have no net clearance from your serum, you want to shift the interleukin, the cytokine storm, away from your tissue that's inflammatorily modulated. And some actually go up, and some have a rebound, and that's also not a good sign that we found. We have small changes for IL-8. We don't have really a good picture for IL-10. And we did see some trend in drops in TNF-alpha in most patients, not to the extent of IL-6, but at least to some extent. And again, it's a logarithmic scale. So numerically, these changes are quite significant or quite large. And that's what we find there, a strong signal for IL-6 reduction in these very septic patients. Drop in IL-6, and that's different between survivors and non-survivors. Some patients increase during or after treatment. That's obviously a very bad sign. There is a small but noticeable reduction in TNF-alpha. We did not find any signals for IL-2, IL-8, or 10 in this small cohort, but we examined them, quite closely. What we also found is that the elimination rates are varying widely. So you really don't have a good picture of what's happening with these patients. For IL-6, there are patients that eliminate from 11 to 83%. Some for IL-10 from 6 to 65, from TNF-alpha 3 to 48. So the individual elimination rate is very, very different. And we don't really know why that is. And that's what we found. Didn't want to repeat that, I'm sorry. And that's what we found. So talking about COVID, as we've all have been for the last 2 years, if we look at, and I just mentioned, variation in cytokine levels, variation in cytokine difference, if we talk about COVID now and what we want to do with them, not septic patients, but COVID patients, the first question you actually have to ask yourself, is it a systemic cytokine storm? And this paper by Cox et al., published in 2020 in JAMA, actually tried to look at that. And they compared COVID patients with ARDS to sepsis patients with ARDS, sepsis without ARDS, out-of-hospital cardiac arrest, and trauma in TNF-alpha, IL-6, and IL-8. And what you find is the levels are increased in all of these cytokines, however, not to a degree of patients with sepsis, with ARDS, for example. They are more on a level of trauma and out-of-hospital cardiac arrest. So yes, there is an increase in COVID-19 in circulating cytokines, but it's less than sepsis. The increase is similar to non-septic ARDS, out-of-hospital cardiac arrest, or trauma. And that's, of course, that of course makes you think, well, is every COVID-19 patient a patient that I need to treat with a cytokine removal device? Or do I need to measure first? Because you're not treating all ARDS patients with that. You're not treating all of cardiac arrest patients with that. And you're definitely not treating all trauma patients with that. So picking the right patient here is, again, difficult because you need to measure and get an individualized picture of your patient. And that's also something we find if we talk about medication and cytokine modulation. in those 3 RCTs about tocilizumab, the IL-6 receptor blocker, Covecta, Recovery, and Remap-Cap. And I mean, these are all highly published trials from the last 4 or 5 months. Rosas in the New England Journal, Horby et al. In Lancet, Gordon in New England Journal. Large trials, almost 300 TOTSI patients versus placebo, 2,000 patients, 400 tocilizumab patients, ozerelumab versus 400 placebo, and they have good endpoints, and they find different things. And that also has to go into account if we think about COVID and cytokine removal. If you looked at Covecta, it's negative. Covecta does not find any survival benefit for IL-6 blocking in COVID-19, and these are sick patients. They have a significant mortality burden, but there's no difference between tocilizumab or placebo. Might have been that it's underpowered, and there's also no change in the Covecta trial if you look at these ordinal scales of clinical improvement. So Covecta is negative, might have been underpowered, but it's not as if you're doing great benefits by blocking IL-6 in each and every patient. Recovery and Remap-Cap are positive. They show a significant decrease in mortality versus usual care, and usual care included dexamethasone or prednisolone or hydrocortisone. And the mortality difference is large, and the confidence interval is significant. So that is positive. And also for the percentage discharge alive. And these are Remap-Cap. Remap-Cap, remember, uses a different kind of statistic, Bayesian statistics. So they come up with a prediction of not absolute values, but relative values. And either one or the combined pooled interleukin-6 receptor antagonists are superior versus control in the cumulative patients of patients free of organ support. So in this patient cohort, blocking interleukin-6 actually does something. Remember, the levels were all not really measured closely. And these are some other curves, again, for survival. Again, tocilizumab, zerlumab, or combined is superior for survival and discharge from ICU. So I think you have different patient populations, you have different settings, you have different numbers. What do we take out of this trial? Because if we're talking about immune modulation using cytokine hemoperfusion devices, it's a bit similar to tocilizumab and just blocking IL-6. Well, we're talking here about patients with COVID-19 in critical care. They are not on the normal ward. They get 8 milligrams per kilo body weight. They get it early in the disease. Those effects that you see are not in the late stages with bacterial or fungal superinfection, and they are driven by the patients without multi-organ dysfunction, and they are driven by the patients that are not on a ventilator. It's driven by patients who are non-invasively ventilated on high flow, nasal oxygen, or just breathing supplemental oxygen. So there was no clear benefit in recovery for patients that were ventilated for more than 24 hours. So identifying the patient, again, is important. Identifying the timing, identifying the patient that benefits are important things. And I think that's the reason why this trial, looking again at hemoperfusion in COVID-19 and ECMO, is negative. Those are very small numbers again. It's Supadi et al. So 34 patients, 16 with venous ECMO with and without cytokine absorption. These are sick patients. They're on a ventilator. They're ventilated with lung protective approaches. They are in severe ARDS. They are not in multi-organ failure. And they get this cytokine removal device. And the trial is negative. There's no clear difference for serum interleukin, which was the primary endpoint. It was a bit lower in the cytokine group, but again, very low numbers. I'm not sure a patient with an IL-6 of 90 actually needs something removed. There's not really much going on in the secondary endpoints, and the reasons for death are the typical ones for ECMO patients: multi-organ failure, hemorrhage, or septic shock. So again, the levels of IL-6 are increased. I think these patients here up here probably would benefit. I'm not sure about patients here. down there. And definitely would not put anybody in my ICU, even if they're on ECMO, on some kind of cytokine removal device if their IL-6 is around 100. I think that is a patient who does not need this treatment. And that's why this probability of survival is so different. And actually, there's a sign of maybe harm in this trial because the mortality in the treatment group was actually higher than the control group. So you have to think about what you do. Hemoperfusion in COVID-19 ECMO, not for every patient, is what I would take out of this trial because there's no benefit, there's potential harm. It is a small sample. I'm not sure if it's the correct patient population. I'm not quite sure if in COVID-19 systemic IL-6 is a good marker for local hyperinflammation. A lot of questions to be asked, low event rates in the control group. So I'm not sure this is such an important trial, but it's the only one actually so far published that's a randomized trial in COVID-19. We have some data on COVID-19 and hemoperfusion from our patient groups. The first wave in Aachen, we were hit by COVID-19 around February to March in 2020, and we looked at the first 8 at some of the patients we actually treated. So these are as a group of 12 patients, and we have survivors and non-survivors. And you can see actually these patients again are increased. We have some in there who have low IL-6 around 500. Everybody actually decreases and they stay down. The deaths decrease and some of them increase again. It's not a clear picture what's actually happening there. So because of that analysis for the second and third wave that we experienced, we are sticking with our approach for septic patients. More than one organ dysfunction, 2 at least, established need for CRRT or ECMO, and an IL-6 more than 1,000, because we don't really know what's going on in there. Even though it pathophysiologically works, we are removing cytokines if you use an HA380 in these patients. And again, that's where we want to be. We don't want to cause additional harm. We don't want futile patients. We don't want the ones to get better anyways. Because absorption therapy does have pitfalls. You know, you do have unwanted side effects with everything in medicine, and they might be overlooked. And that's a problem because these patients are so sick. The sicker your patients are, the more likely you are to overlook confounding factors or adverse events. And you must monitor them carefully, therefore. Bleeding, clotting, increase of coagulation disturbances are one thing. Leukopenia has been described. Drug removal alteration, that's a big thing. I think if you have patients where you have extracellular volume increased and you remove drugs maybe with an additional device, you might end up with underdosing antibiotics, and that might be fatal for the patient. You might remove albumin or nutrients, or you change electrolyte levels. A lot of things can happen if you put patients on extracorporeal devices, if you put them on Cytosorb or HA380. And we're not monitoring this closely, but I think we should. So having said all of that, where are we going in Aachen? Where are we going to from here? With our pilot trial, we don't think we caused harm, and so we are quite sure we can continue doing that because we showed some correlation for improvement in markers of shock. And that's the first goal. I know everybody wants to do trials on 30 and 60 and 90 and 180-day mortality, but if you use this therapy, you're not thinking about that. You are trying to resolve shock, and then you're hoping that quicker resolving of shock is associated with better survival. But your first goal, your endpoint, is reduction of organ dysfunction or avoiding further organ dysfunction. So I think any trial should measure that. And then you will have to see whether it independently affects mortality. And we must identify a good population to actually study this, and this is what we are trying to do. This is the trial that I'm PIing. It's an observational trial. We're trying to include in the first wave 100 patients. It's multi-center prospective observational. We are including patients with sepsis and at least 2 organs that are not functioning, with an established need for CRRT or ECMO, because we don't want to hook somebody up to an additional machine just because they might be on non-invasive ventilation and use vasopressors. We want something established where an additional machine will not cause harm because the patient is on ECMO or CRRT anyways. We started this project, started enrolling in winter 2020. We will be enrolling for 2.5 years. over 2 years including, and a follow-up for 3 months. This is the primary objective. We look at cytokine variability in the patient's serum. We have secondary objectives like cellular function, talking about homeostasis again, efficacy of the device. Nobody really knows if your device has good efficacy at the beginning and then tapers down, or if it stays well over 8 hours, or maybe you could use it for 12 hours. We look at markers of shock and markers of ventilation. We look at markers of organ dysfunction. We are measuring antibiotic drug levels. We're looking at ventilator-free days, ICU, hospital length of stay, 30 and 90-day mortality. Those are all the things we're measuring. This is a short print of our ECRF items, and you see we enroll patients. We have a baseline, and then we measure every 2 hours blood samples during treatment. We do 2 sets of treatments, one for 8 hours and a second one for 8 hours. In between, we have a 4-hour gap where we want to look at a rebound, and then we follow the patients on the ICU daily for 7 days, and then we follow them up 30 or 90 days after. And we are recruiting right now. We are initiating Chinese and Belgium hospitals because we want to do this multicentric and we want to enroll patients quickly. And so far, we are little bit above 10% of our goal. We are around for 15 patients. This is my talk, and these are my ideas, and I think that's the basis for the round table. Where do we use it? Which population is going to benefit? What are the trials we need? What is your experience in COVID-19? My experience as well. I'm not sure COVID-19 is the cytokine storm in each and every patient that it's supposed to be. I think it's local inflammation. But this is the things we might want to discuss right now. Thank you.
Thank you, Professor Alexander, for this outstanding talk. We are very happy to hear from your valuable experience. And also we are happy that we have with us now 2 of the top leading intensive care unit manager in Morocco, Professor Shafiq Tani and Professor Ahmed Ghassan Al-Adib. Both of them have long experience in the managing intensive care units and managing COVID-19 patients with or without sepsis and with or without cytokine storm. Professor Ktani, we are happy to have you with us. Professor Ktani, vous m'entendez? Andre, can you unmute Professor Ktani?
Yes, I'm with you. Thank you, Mr. Alexander, for the presentation. It was very, very clear, and we are glad to see some scientific data concerning the use of the continuous renal replacement therapy in COVID patients. We have in Casablanca not a lot of patients with the CRRT, continuous renal replacement therapy, but we have a bad experience. No survivors from 12 patients. That's what's, but there were sepsis, there were a high level of interleukin, and we have not good experience with COVID patients.
Yeah.
But we see that the absorption can be useful, but we are probably in the septic patients, but now we have no experience in this field.
Yeah. I think so. I completely agree. I have the fortunate situation that in each and every of my patients, I can measure IL-6 daily. So we measure PCT, we do whole blood counts, we measure CRP, we measure IL-6, and I get a same-day result. So all the bloods are drawn at 3 o'clock, and when I arrive here at 7 in the morning, everything is there, and so we have daily IL-6. And our experience for COVID is that most of them don't have high systemic IL-6 levels initially, and they go up when patients get, of course, bacterial superinfections, but we see patients who are severely sick with 1 or 2 organ dysfunctions, and early renal failure without high IL-6 levels. And those we don't treat with that. We treat them when they become septic with cytokine absorption. One problem with IL-6 levels in the initial phase that we see, and maybe also with the generous use of hemoperfusion devices in COVID patients, actually you should treat some of the patients with tocilizumab. There is evidence that it can help. So you treat a patient with tocilizumab, you give it to him once or maybe on day 1 and 2. That's what some of the trial patients received. And then IL-6, of course, will go up because you don't have receptors incorporating it. But how do you classify that? And when does it go down again in these patients? So we're creating a bit of problems in identifying the patients that might benefit from hemoperfusion with oral treatment there. But overall, our experience was over this last year or more than a year that many patients don't have IL-6. Even my patients on ECMO have IL-6 levels around 100 if they're not septic, and they do not need cytokine removal because you're not doing anything good, because they probably are in some kind of homeostasis, at least systemically. Locally, for their lung, they probably have hyperinflammation. However, whether that is cytokine driven or is cellularly driven, also nobody knows. If you're talking about a T-cell reaction there, or autoimmune inflammation that happens because of persistent virus shedding, you're not going to do any good in removing IL-6. You need to do something else. You need to do something that's targeted at T cells. So we're talking about a different disease entity from other viral diseases like influenza, like the flu. We're talking definitely about a different entity, at least at the beginning, from patients with bacterial pneumonia and sepsis or intestinal sepsis. Yeah. Our experience in mortality, we see, of course, a selected picture as a large university tertiary care center, is that we had mortality rates for ECMO patients, for example, in 2020, around 35% to 40%. So we felt really well. We felt we were doing good. And in the second wave, we have mortality rates over around 70%. So patients are a lot sicker. More of them are dying. We see more liver failure, GI failure, these things. So it's really hard.
Thank you, Professor Alexander. Thank you, Professor Kettani. Professor Kettani, I think, also has a great experience in the management of patients with the high level of cytokine with tocilizumab. Professor Kettani, can you tell us a little about what is your approach for the management of septic patients, COVID positive, with tocilizumab?
Yes, Mr. Alexander talked about tocilizumab before. In my opinion, tocilizumab can be indicated in severe.
We hear you very well.
But it had to be used early, and we have to identify there is no sepsis, bacterial or fungal sepsis, because tocilizumab reduces the biomarker of inflammatory. But if there is infection, the second infection, it's dramatic. But we have to use it in the severe patient. We have to use it early, and we have to monitor the clinical and biomarker of the sepsis and to adjust antibiotic therapy. That's what's, in my opinion, the good indication of tocilizumab. We have treated about 100 patients in the 6th month, and the good patient, we are studying now our results, and the good patient with tocilizumab, that patient treated with form not yet intubated, not invasive mechanical ventilation, not infected. That's the good indication.
Thank you, Professor Kettani. Professor Jabran, Professor Mtiwi, have you any Any intervention, any question? Professor Mtiwi?
Ladies first, maybe.
Professor Jbran?
Okay, I have a question. Thank you, Minister, for your presentation. I have a question. Sorry for my terrible English. Sorry for my terrible English, but I'm trying to do my best. I would like to ask you, how do you use absorption? Let's say in the last recommendation that is written, we say 2 hours during 2 days, alors 2 heures, 2 fois 2 heures, c'est ça? How do you use it, and how can we use it in intermittent hemodialysis? How can we use it in our context?
Yeah, that's a good question. So how we use it is we don't put it on intermittent dialysis machines. For the ICU, we use CRRT, Gambro or Fresenius machines, multifiltrate, and then we have SLED devices where we you have these genius big tank machines where you actually cannot hook them up into the circuit that does not work with the machine. When we use it, we have inside the trial, we have 8 hours of treatment. If I have a patient outside of the trial, we actually usually go to 12 hours and then stop. And since we get daily measurements, we look at the patient, we do 12 hours, we see where is his IL-6, is he getting better? Is it still above the cutoff that we would use to actually start treatment? Maybe he went down from 10,000 to 5,000. And then we will get a second round of treatment. However, if he gets close to 1,000, we would stop treatment. Or if he gets really, really much better, his lactates clearance is completely normal, his vasopressors are completely down, something like that, then we would actually stop after 1 round of treatment. And then you just need to keep looking at your patient. For intermittent dialysis, again, we don't use it. I know that the Chinese actually have a lot of outpatient dialysis where they use hemoperfusion in intermittent dialysis, like once every 14 days or so, or once every month. And they see patients, we're not talking about critically ill, we're obviously talking about maintenance dialysis. They see patients that are actually benefiting from that. They have better phosphate levels, their calcium is better, they have less inflammation if you measure CRP as an inflammatory marker. And that has probably something to do with the device, but also probably something to do with how they dialyze. I think in most Asian countries, the interval is twice a week. For Western Europe and the US, where I've worked, it's 3 times a week. And of course, there the dialysis dose is maybe different. That's basically my experience for intermittent dialysis. Our nephrologists here do not use any hemoperfusion device outside of the ICU. Whatever device you're using within an ICU, I think it's actually easy because it can be hooked up with any machine. The flow resistance is so low that none of the machines will actually notice it. It's safe because it's veno-venous. You have to, of course, prepare the absorber, and you have to prime it. But even if there are some residual tiny air bubbles, if you hook it upstream of your dialysis filter, you will catch those air bubbles anyways. They will not go into the patient. And that just works fine. And then we just detach it after 8 or 12 hours from the CRRT and continue doing the CRRT without it. And one thing we do find is that citrate anticoagulation is, of course, very nice because you don't get any clotting whatsoever in your absorber.
Thank you, Professor Alexander. Just to emphasize what you have said, hemoperfusion technology, it's a membrane, a filter that we can add ideally to a CRRT machine. But also we can do hemoperfusion with hemodialysis, classical hemodialysis machine. As you have said, in China, they are using hemoperfusion plus conventional hemodialysis for the management of patients in intensive care units, but also for the management of chronic hemodialysis patients. they are using intermittently once a week, once a month, a hemoperfusion session. But for another indication is to eliminate, to epurate middle molecules, because hemoperfusion technology can eliminate molecule with a molecular weight above 15 Dalton. And it is the molecular weight of most of cytokine. Because I think this is why the same technology can be either used in intensive care units for sepsis or for COVID-19 patient, but also for patient with chronic hemodialysis.
Yep. Completely true. I did not show that in my slides. You know, you're removing things between 10 to 15 up to 60 kilodalton. So a lot of cytokines are there, pro and anti-inflammatory. A bit of albumin is there too, so you're going to remove some of that maybe. Bilirubin is there in that range, a lot of things. And basically, you're just doing a net removal. The higher the concentration of something is in your blood, the more you're going to remove per pass. So it's just basic physics. And you can hook these adsorbers, you can hook them up to any device that pumps blood from A to B. So you can do it standalone. Some centers do that. And you can do it with any device. We sometimes do it here for patients who get bilirubin absorption. There are others adsorbers who just, you know, are where you do plasmapheresis, and you then push the serum through an absorber to remove bilirubin, and you can hook a cytokine absorber afterwards, and you reduce inflammation again. So the mechanics are actually easy. You just need some kind of pump, and you need a large bore access to veno-venous circulation, like a Sheldon dialysis catheter or something like that. I think that the problem is not the mechanics. The problem is identifying the patient that's going to benefit at the right time. And that is much more difficult than one might think, because as any therapy, it's like a drug. You have side effects, and you wouldn't give antibiotics to patients who doesn't have an infection. You wouldn't give dialysis to a patient who doesn't have renal failure. So you cannot or should not give hemoperfusion to a patient who doesn't have a problem that can be solved with hemoperfusion. And we have trouble finding the right patients, I think.
Of course. Professor Mtsiwi, any comments?
Yes, thank you, Professor Alexander, for your interesting talk. In the same context, I think, as talked last time by Professor Kitani, it's the magic term to use when using our tocilizumab is the time to take. We have to make it early before we have the damage, the damages. Is this the same thing? I think it is the same thing. For the hemoperfuser, you have to choose the ideal time.
Yeah, I think you're probably
Sorry
right.
for my English.
No, you're very clear. I think you're probably right, because you're not gonna rewind multi-organ failure. So a patient whose kidneys, liver, coagulation, hemodynamics, and lungs have failed, you're not gonna wind that back and make the organs recover magically. It would be much better to identify the patient at risk and then stop the other organs from being damaged. And of course, I think that the problem in my day-to-day ICU life is which patient is at risk. All of my patients are at risk for dying. That's why they're in the ICU. Most of them are at risk for multi-organ failure if they have sepsis, because they have comorbidities and so forth. One reasonable approach to identify the ones that are just sick enough are the ones where, you know, it's not just one organ, but a second one is already injured. And I think the one where we have most experience in defining injury is kidney. We have done so much work with the ADKey initiative, with KDIGO, in defining kidney injury in the critically ill. And I think we have a large consensus worldwide what acute kidney injury is in these patients, even though we have different approaches to when to dialyze a patient. But we all can basically agree on kidney injury in the critical care setting. That is an interesting selection tool. You have somebody with sepsis, and with sepsis, you have definitely defined that with the SOFA score. Good. You have identified infection or have suspicion of infection, so he has sepsis, and then it's a second organ that's not working. And I think renal failure is really really sexy for that, because it's well defined, it's good to measure, we know how to treat it, it's common, a lot of patients have that. So you're talking about a lot of potential interesting patients. We know it's relevant for short and long-term prognosis, even in light stages. You know, if you have pneumonia and KDIGO 1 kidney failure, your 6-month mortality is still higher than having pneumonia without kidney failure at KDIGO 1 stage. So I think that's why I'm really into defining patients on the basis of that, and most of them are defined not because they have liver failure or DIC. Most of them are defined by, you know, they have sepsis, they need ventilation, maybe invasive or non-invasive, they have some kind of vasopressor need, and their kidneys are deteriorating. And those are the ones that I would always want to treat if their IL-6 is high. If their IL-6 is not high, then maybe their organs are failing because they have chronic damage that nobody noticed before, and it's not acute inflammation.
Okay.
Thank you. Thank you.
Early.
Any comments? Micro. Professor Kseni.
Question before beginning the chemotherapy, what are the parameters that we can use to indicate that the therapy with like ECMO, venovenous ECMO? Is it biological markers or clinical markers?
I think it's clinical markers. I think clinical markers are usually better than anything you can measure. Right? And if you have the luxury of having both, get fast measurements of lots of interesting stuff, then of course you're lucky. But for me, I think noticing a patient who has a problem like sepsis, and he does not respond well to your standardized treatment. You give antibiotics, you give fluids, you give vasopressors, you treat the underlying infectious focus, like, if he has cholecystitis, you treat that. If he has pneumonia, you treat that. If he has appendicitis, you remove the appendix, and so forth. And if the patient does not then get better quickly, and quickly is, of course, I don't know. For me, quickly would be, like a nurse shift. And we have 3 shifts a day, so maybe 8-hour shift. If he doesn't get better within 1 shift for the nurses, then maybe you need to do something else before you wait another 24 hours. I don't think there's a standard for that, but that's just my approach. So clinical markers, yes. ECMO is difficult because there's so many different ways to put somebody on ECMO and different cutoffs. I think ECMO does cause inflammation in patients. Obviously, putting cytokine absorbers in every ECMO patient does not make any benefit. So you still need to identify patients based on clinical measurements. Are they septic or not? And sepsis is not a laboratory, is not a blood diagnosis. It's a clinical diagnosis at the bedside. That's why sepsis 3 is by Dillinger is so great, because it's something you see at the bedside. And that would be my primary point. With the machines, again, I don't feel very comfortable in putting a patient on hemoperfusion and hooking it up to a machine if he does not have any other need for that machine. So putting somebody on a roller pump just because I want to do hemoperfusion because his IL-6 is high, I'm not sure that's good. I don't think it will cause much harm, but it might. You know, if he does not have a large catheter for blood to go in and out, and I create a pneumothorax, I might do harm. If he has that catheter already because we're doing other things that are absolutely necessary, like dialysis, then why not do hemoperfusion if the patient fits?
It's clear, Professor Alexander. Any question?
Yes, if, Professor Alexander, did you perform the conventional hemodialysis in your patients, in your COVID patients? No.
Well, on the ICU, we only do CRT. We do CVVHD.
Of course.
So we all, and that's basically because, of course, we are a large German hospital, so we have the luxury of having all these machines. It's easier for the nurses. You know, the nephrology department sets up the machine. My nurses run the machines, and they, you know, they run nicely 24 hours at all time. So yeah, no, our standard is not intermittent dialysis. Well, our standard is CVVHD, not CVHDF, but CVVHD.
And what about the anticoagulation for CRT machine? You are doing anticoagulation with citrate or with heparin?
Citrate regional anticoagulation as a standard, even if the patient has other reasons for heparin. So, you know, you have a patient with atrial fibrillation, and he of course he has heparin and he has an APTT of 50. I would still put him on regional anticoagulation because it just works better, it lasts longer. We just have more quietness of the machine running. And if something starts bleeding, I can just turn off the heparin and give an antidote or give plasma, and the dialysis machine will still keep running. You know, CRT will still work. And so our standard is citrate anticoagulation in the circuit, even in patients with a liver dysfunction. And we are very comfortable with that, and we've been doing that for years.
Thank you. Professor Jbran? Micro.
Well, I have no other question rather than saying that we need to maybe involve ourselves in continuous techniques, because we have seen during COVID-19 that we lack, we have lost many patients due to, maybe not due to intermittent dialysis, but maybe we could have saved more patients with continuous techniques.
Yeah, we do see a lot of renal failure in the critically ill COVID.
Yeah, I know that.
It is horrible. Like we actually, because we treated so many patients here as one of the first hotspots in Germany, we actually had to, you know, borrow machines from the dialysis companies. So we borrowed Fresenius and Gambro machines because we did not have enough machines for all the patients. Yeah, it's bad.
Okay.
Professor Ktani, des remarques?
No question, but we have to use the continuous therapy in intensive care. I think it's the time to begin in the big cities and in Morocco, in Marrakesh, Casablanca, Rabat, and Fez. We have to start because there is teams, teams, and can work together to implement the technique for our patients.
Professor Naufel, une question, remarque?
No, thank you. No, thank you.
So, thank you, Professor Alexander, for this kind meeting. We are very happy to hear from your experience. Thank you. So we will continue a few minutes in French.
Okay.
So thank you, Professor Alexander.
Thank you for having me.
In a future meeting.
Yes, see you in person next year, probably again, everybody. Well, Then stay
I hope.
safe.
Thank you.
Thank you.
Donc, merci, professeur Ktani, pour votre participation qui nous a enrichis, nous, néphrologues. Seul, on ne peut pas prendre en charge ce genre de patients. On a besoin du réanimateur parce que ce sont des patients avant tout de réanimation. Et c'est l'occasion pour qu'on discute entre nous comment on peut aller de l'avant et trouver ce moyen de collaborer. Vous avez une expérience magnifique durant la période Covid et avant. C'est pour ça qu'on a insisté pour que vous soyez avec nous pour nous guider. N'est-ce pas, Nopel? N'est-ce pas, Javran Fatem Zahra?
Bien sûr, bien sûr. Et comment?
Moi, j'ai une question. Est-ce qu'à Marrakech, vous êtes en high cut-off quand vous dialysez des Covid en réa ou est-ce que c'est du low
La deuxième partie, on a commencé à les dialyser avec Terra Nova. High cut-off, medium cut-off.
Et ça, vous ne perdez pas avec la Terra Nova?
Comment?
L'albuminémie, elle ne baisse pas un petit peu quand vous utilisez la Terra Nova par rapport aux autres high cut-off?
Non, l'idée, c'est que comme s'ils ont un IL6 élevé, donc on passait à la dialyse avec les membranes Terra Nova qui ont eu un ATU européen dans l'indication Covid. Donc, c'est des membranes qui permettent d'éliminer les cytokines. Donc, on a suivi les recommandations.
Et tu as constaté une différence en termes de survie ou?
C'est difficile à dire parce qu'on a eu une mortalité globale aux alentours de 60% des patients en réa à l'hôpital militaire. Mais pour les patients qui avaient une insuffisance rénale, comme tu le sais très bien, ils ont une mortalité supérieure. Sur les patients qu'on a dialysés avec sepsis et Covid, donc on va dire toute la série, c'est une vingtaine de patients avec IRA, Covid et IL6 élevé. Sur les 20, on a eu 12 morts et 8 qui ont pu survivre. Mais c'est une petite série. Je ne peux pas te dire que c'est quelque chose de consistant.
C'est excellent.
C'est pas
très bien.
On ne vous entend pas très bien, professeur Kissani.
Si vous avez eu vivant sur 20, pardon.
Ça coupe, on ne vous entend pas.
Micro.
Oui, je pense que si vous avez 8 survivants sur 20 qui ont nécessité une technique de d'hémodialyse avec un taux d'interleukine très élevé, c'est un très bon résultat. Je voudrais savoir, est-ce qu'il y a eu une différence dans l'évolution de l'interleukine 6 chez les deux groupes, survivants et non survivants? Parce que nous, sincèrement, que ça baisse ou ça augmente, parce qu'ils avaient du tocilizumab en priorité, mais la mortalité est élevée quand ils étaient en insuffisance rénale. Même si tu as amélioré…
Au stade, on était à 100%.
Oui, on les perdait tous.
Sincèrement.
Professeur Adib nous a rejoint, donc on est content de l'avoir.
Bonjour. Bonjour, j'étais très entreoccupé, ça m'intéressait beaucoup la présentation. Moi, je suis un fervent croyant en ces techniques. À la fois dans le cadre, moi je fais de l'obstétrique, j'ai beaucoup de maladies immunitaires, de syndrome catastrophique de phospholipides, microangiopathie thrombotique. Et donc même avant d'arriver à la dialyse, j'utilise beaucoup d'échanges plasmatiques par les différentes méthodes. J'ai un appareil multifiltrate dans le service depuis 4 ans et je n'ai réussi à faire qu'une patiente il y a 1 mois et demi. Par beaucoup de problèmes logistiques et ça a marché très très bien. J'ai d'excellents résultats avec ces techniques de plasmaphéreuse et l'équivalent de CRT. Par rapport à la Covid, on était convaincus dès le départ que c'est une technique extrêmement importante. J'étais en contact avec Jaffran depuis le départ, il m'a envoyé beaucoup de choses, j'ai assisté à des séminaires à eux. Je sais que ceux qui nous précèdent dans ce domaine, c'est Oujda. Ils ont une grosse série, j'ai dû suivre avec Husni pas mal de patients, chez qui même un enseignant d'entre nous qui a eu le tocilizumab, qui a eu pas mal de choses, et le sauvetage était grâce aux échanges plasmatiques. Donc, je ne maîtrise pas encore les techniques de CRT, c'est pour ça que je ne veux pas m'aventurer beaucoup, mais je crois que c'est des techniques qui sont extrêmement importantes, obligatoirement à développer, particulièrement là où il y a des équipes relativement étoffées, où il y a de la recherche à faire. Et donc, je vais tout faire pour m'équiper, pour faire plus de malades avec ce que j'ai. Allah ykoul khair. Maintenant, par rapport aux malades qui ont besoin de dialyse, ben, il y a beaucoup de perspectives. Et puis, nous, dès le départ du Covid, je pense que le professeur Mtsioui est avec nous. L'équipe de néphrologie de Casa, il a un staff incroyable, où il y avait la discussion sur les techniques d'hémodialyse. Et j'attendais avec impatience un article à eux. Ça serait peut-être intéressant de nous dire par rapport à ce que vous avez discuté la dernière fois. Je suis un peu parce que je n'ai pas pu suivre clairement tout depuis le départ.
Merci beaucoup, professeur Hadi, pour votre expérience et pour votre feedback. Vous étiez au front depuis des mois, donc on suivait vos interventions partout. Donc, vous parlez du cœur de la bataille. Donc, l'idée, c'était, il y avait un grand article dont on parlait, nous, les néphrologues, d'un grand monsieur de la néphrologie, Claudio Ranco, qui disait pour préparer la paix, on prépare la guerre. Oui, il parlait de la Covid avant qu'il atteigne l'Italie. Et donc, se préparer à la guerre, c'était venir en réa ou en néphrologie avec les inhibiteurs des cytokines, avec toutes les techniques d'épuration, avec l'ECMO, avec les machines d'extraction de CO2. Tout doit être prêt. Peut-être on a raté ça la première vague. On n'est pas à l'abri d'une deuxième ou une troisième vague ou une autre pandémie.
Et si c'est les filtres, c'est beaucoup plus les filtres, c'est beaucoup
Bien
plus
sûr.
le matériel.
Le matériel, on l'a. Peut-être les sociétés doivent former un peu plus les équipes et maintenir les formations. Parce que je sais que même les CHU, les hôpitaux militaires, tous ont des machines de continu, mais l'utilisation n'est pas régulière. Et ça, c'est un grand problème. Je ne sais pas, professeur Mtsioui, il peut nous raconter son expérience sur ça.
Alors ça, j'en ai pas parlé une minute. Alors nous, on collabore beaucoup avec le service de néphrologie. Ils arrivent carrément à déplacer leur équipe chez nous. Et on a aussi un service de plasmaphérèse. Mais là, c'est un problème de ressources humaines qui se pose. Même quand on a le matériel, je pense que la collaboration néphrologie-REA est quelque chose de crucial. Dans les services de REA, où on doit être impliqué quand les malades sont déplacés sur place.
Bien sûr.
C'est sûr, Adib, merci beaucoup. Alors, pour l'expérience, en fait, on était à 100%, 99% d'hémodialyse conventionnelle. Et le travail sur lequel on s'acharnait, on voulait publier et tout, malheureusement, sincèrement, ça va être difficile de proclamer 100% de mortalité. Alors, le constat qui a été remarqué, si vous vous rappelez de la petite présentation qu'on a eue ensemble, c'est surtout que ces patients en hémodialyse conventionnelle, on délivre beaucoup de CO2. Rajoutant à cela le terrain pulmonaire lésé, les échanges sont lésés, donc c'est une rétention, c'est un bilan positif de CO2. Moi, sincèrement, je le dis clairement, que ça fâche ou pas chez nous, même chez nous au service, pour moi, hémodialyse conventionnelle, c'est désadapté en réanimation. C'est les techniques continues, surtout en matière de Covid. Et puis, on a eu la chance d'accompagner l'équipe du pavillon 37 bis, avec le professeur Ellam. On a eu un patient, c'était pour une autre chose, ce n'était pas une Covid. C'est un patient qui est opéré du cœur, il fait son insuffisance rénale, un remplacement valvulaire mitral. Et moi, ce que je retiens de cette expérience, il y a eu une belle collaboration. Et on avait un malade sur un plateau au nord. Pourquoi? Il était anticoagulé, il était sous ECMO. Et on puisait de l'ECMO, on avait un très bon débit, le pompiste CC1, il était excellent, on avait de bonnes pressions, on a fait la technique continue et on a tenu une semaine avec seulement 4 kits. Donc là, c'était l'expérience pour moi modèle d'une collaboration, de prescription, parce que nous-mêmes, on n'avait pas la main. Mais cher Ramdani, l'ancien TDL, bien sûr, il nous aide, il nous chapeaute, on essaie de faire ensemble, ou toute l'équipe. Et on arrivait à tenir ça. Donc, pour moi, c'est technique continue. Il faut que ça sorte du lot, qu'on sorte de ce lot d'hémodialyse conventionnelle, sincèrement. Et c'est la collaboration qui doit subsister. Nous, on sait manier un petit peu ce qui est matériel, et je ne sais pas si le professeur Kitsani pourrait le confirmer sur les techniques continues qu'on a eues sur CASA, c'était toujours la problématique de la coagulation. Donc, c'est des paramètres techniques, encore d'ingénierie qu'il faut surveiller, et je pense qu'il faut collaborer dans ce sens.
Clairement. Les cas qu'on a évoqués, bon, à qui on a mis en place.
Micro, professeur Kitsani.
Pardon. Pour les patients à qui on a mis technique continue au CHU, ça nous a facilité la tâche de leur prise en charge et ça a duré. Ils sont décédés, hein, une douzaine de patients, ils sont décédés. Alors, pour moi, le problème, il n'est ni sur le plan matériel, ni sur le plan humain médical, c'est le problème paramédical. Il faut former le personnel. Et il faut que le personnel soit mixte. Il faut qu'il y ait des gens de la néphrologie qui vont venir travailler en réa et des gens de réa qui travaillent. Nous, on ne peut pas avec les patients. Donc, on a eu des problèmes de coagulation, on a eu des gags pour ces patients, aussi bien en ECMO qu'en hémodiafiltration continue. Donc, et le problème pour moi est plus humain pour le personnel paramédical. Médical, les néphrologues n'auront pas de problème à s'adapter aux techniques. Les réanimateurs n'auront pas de problème à s'adapter aux techniques, mais il faudrait qu'il y ait des gens qui restent à côté du patient. C'est-à-dire qu'il ne faut pas lâcher le patient. Et qui connaissent, c'est en restant à côté du patient qu'on va optimiser notre façon de faire. Au 17, on a fait par exemple un travail sur l'utilité de TCA, c'est une technique de monitoration anticoagulation en réanimation, parce qu'on avait effectivement beaucoup de problèmes de coagulation et de saignement. Bon, ensuite, je pense que ce n'est pas la bonne école. C'est des patients avec qui on va apprendre. Hein. C'est des malades très difficiles,
Oui,
mais
sûrement.
le frein, c'est la formation du personnel paramédical et il faut que les gens soient humbles et collaborent. Et les néphrologues et les réanimateurs.
Exactement. Je pense qu'il faut toucher les providers dans ce sens, surtout qu'ils incluent le personnel paramédical dans les formations qu'on suive avec eux, surtout.
Je pense que vous avez mis le point sur le cœur du problème, parce que là, ce n'est pas le fait d'acheter une machine, acquérir une machine, et le problème est réglé. C'est une thérapie. Et les providers ou les fournisseurs doivent jouer le rôle, non pas de nous montrer comment allumer la machine, mais nous former à la thérapie. C'est une thérapie, ce n'est pas une machine à allumer et à éteindre. Donc, formation du personnel, formation du médecin, néphrologue, du réanimateur, et le personnel doit être formé en continu. Normalement, pour CRRT, on délivre une licence de manipulation qui expire dans le temps. Donc, normalement, c'est une formation sanctionnée par un certificat et le médecin ou le technicien ou l'infirmier n'aura pas le droit de l'utiliser au-delà d'1 an. Il doit passer un test avec la société qui l'a formé pour avoir sa licence. C'est comme ça qu'il faut réfléchir. Et ça doit toucher l'équipe de néphrologie et l'équipe de réanimation. Mais c'est le néphrologue seul qui doit connaître la machine ou son équipe. Dans les hôpitaux militaires, par exemple à Rabat, on travaille, on déplace l'équipe dans le service de réanimation, mais maintenant, même l'équipe de réanimation, elle est formée en même titre que l'équipe de néphrologie. Donc, je pense qu'il faut aller dans ce sens. Former tout le monde, parce que c'est un problème qui est là depuis tout le temps. Donc, on forme une équipe, après des gens partent à la retraite, des gens changent d'hôpital, et on se trouve avec une machine donc non utilisée. Vous êtes très bien informé. Il y a aussi le problème des filtres. Juste à titre d'information, pour ces filtres d'hémoperfusion, au Maroc, il y a un filtre qui a déjà eu l'ATU pendant la Covid, au Maroc, de la société Baxter, Oxiris, mais ils ne le commercialisent pas au Maroc. Ils disent qu'il n'y a pas de marché. Et le troisième filtre, c'est le filtre de Jafran. Il est en cours d'autorisation. Il n'a pas encore, comme vous le savez, tout est bloqué côté autorisation. Donc, ils ont déposé le dossier, mais c'est en cours. Solution intermédiaire, comme vous l'avez si bien dit, c'est les échanges plasmatiques. Donc, ça, on peut le faire partout. Et il y a les filtres qu'on appelle les filtres à medium cutoff, qui peuvent éliminer des molécules au-delà du poids moléculaire qu'on élimine en dialyse conventionnelle. C'est des filtres donc, de Baxter ou de Fresenius ou de Brown ou de Nipro. Donc, tous les fournisseurs ont ce genre de filtre. Donc, c'était ça l'update concernant les deux questions.
Alors, au début de la pandémie, tu te rappelles, Anna, je t'avais appelé quand j'étais dépitée, quand on dialysait à l'hôpital chez Khalifa les patients Covid, avec le même succès qu'ailleurs. Et en fait, on avait un moment, nous, on a d'emblée dialysé en high cutoff et on a essayé un petit peu de diminuer le débit de dialyse, de baisser le bicar et de faire une espèce de cinétique de bicar. On a un petit peu tout tenté. C'est vrai qu'on a dialysé aussi, vous vous rappelez, je parle sur la supervision de cette Christianie, on a dialysé des patients, on a allongé la séance de sorte à faire de s'apparenter au maximum à la SLED avec un meilleur résultat, mais de toute façon, on les a tous perdus. Hein. Mais les patients faisaient moins de désaturation en perdialyse. Et puis,
vous avez essayé. Bien.
Quotidien. On était dans du quotidien. Je ne sais pas ce que vous en pensez, vous, dans les autres équipes. Est-ce que ça a été tenté ou là, vous avez peut-être eu une meilleure expérience par rapport au paramétrage de la machine qu'on pourrait, du moins dans la conventionnelle, c'est ce qu'on a malheureusement pour l'instant. Mais est-ce qu'on peut éventuellement codifier ça? En ce moment, on a, alhamdoulilah, on n'a pas eu à les dialyser, mais c'était des patients qui étaient en IRA à l'hôpital. On n'a pas encore, ça fait déjà pas mal de semaines qu'on n'a pas dialysé de Covid, ça fait 3 semaines qu'on n'a pas dialysé de Covid, mais est-ce qu'on pourrait éventuellement discuter d'une codification des machines conventionnelles ou des séances conventionnelles et partir sur ça, ne serait-ce que pour pouvoir transposer les résultats et avoir une série conséquente? Je sais pas si
sincèrement, je dirais non.
Je pense...
Sincèrement, vas-y, Amr.
Vous n'avez pas le choix. Il faut aller sur les deux fronts. Tu modifies le paramétrage des machines conventionnelles, tu allonges pour s'approcher de la SLED ou de la PIRT, 6 heures, 8 heures, mais aussi, comme vous avez des machines de continu, il faut batailler pour les utiliser. Vous avez des machines.
C'est même pas négociable, ça c'est ce qu'il faudrait qu'on...
Il faut aller sur les deux fronts et former les équipes.
La dialyse n'est pas la chasse gardée des néphrologues, il faudrait vraiment qu'on fasse le dé de ça et qu'on se dise que...
Il faut passer la main au réanimateur. C'est ça notre vision.
C'est sûr.
Moi, sincèrement, je ne suis pas d'accord avec vous, je pense. Puisque la problématique dans la codification, il n'y aura pas de codification, parce que la problématique est dans le tampon. C'est le bicarbonate. Dans les techniques continues, c'est le lactate, c'est l'acétate, ça règle tous les problèmes. Vous aurez 0 CO2 qui passera au patient. Même en passant au SLED, il faut demander à ce moment-là à l'intensiviste, au réanimateur, d'optimiser le volume d'échange, d'augmenter la fréquence respiratoire pour éliminer plus de CO2. Mais on est déjà sur une SDRA avec un poumon très lésé. Tout le CO2 qu'on va délivrer. De toute façon,
le poumon, il est déjà...
Ouais. Et pire que ça, si on utilise le high ou le medium cutoff, à ce moment-là, il y aura de la rétrofiltration importante qui va atteindre 8 litres. Il faut avoir de l'eau stérile, certes, ultra pure, mais également à côté de cela, vous allez passer encore plus de CO2. Alors, sincèrement, je proposais même de la dialyse péritonéale pour ça, pour ces patients, pour éviter tout ça, sincèrement.
Si je peux me permettre, je ne sais pas si vous vous souvenez de l'histoire de la Covid. On a eu beaucoup d'insuffisances rénales à des stades très avancés au départ parce qu'on séchait les malades à mort. On ne gérait pas la volémie, ils étaient déshydratés d'une façon incroyable et puis on n'anticoagulait pas au départ. Quand on avait compris tout ça, on anticoagulait aussi, on a réduit d'une façon phénoménale le nombre d'insuffisances rénales, sauf si des malades qui s'aggravent par la suite avec des chocs septiques qui relèvent plutôt des techniques continues. Même le fait de les déplacer, les dialyser, c'est pas facile. Donc effectivement, c'est un plaidoyer à la fois dans le cadre de la Covid pour la prévention des atteintes rénales qu'on va gérer difficilement, et puis qu'on installe le continu. Et avant qu'il y ait l'insuffisance rénale, moi, je pense qu'il faudra, j'attends impatiemment qu'un papier de Oujda sorte, qu'il y a des papiers espagnols. Les échanges plasmatiques, c'est quelque chose d'extrêmement important. Je pense qu'ils vont gagner énormément. Et en plus, on n'a pas besoin de tout le tralala avec la coagulation. Il y a des petites machines qui font les choses, les techniques c'est pas la centrifugation, par filtration. Qui rendent, oui, les techniques par filtration avec des petites machines simples. Même la littérature il dit qu'il y a une assez grande équivalence et dont la courbe d'apprentissage est extrêmement rapide. Donc, mais n'empêche qu'il faut qu'on fasse les choses ensemble de toute façon.
Exact.
Excellent.
Dernière question, je ne sais pas si vous avez l'information. Zama, est-ce que vous pouvez, entre les différents filtres adsorptifs, le 330 et le 380, est-ce qu'il y a une étude comparative en dehors du Covid ou là, est-ce que c'est…
Pour ces filtres, il y a des filtres en fonction des indications. Il y a le 380, il est pour les cytokines, notamment IL6, IL1 et TNF-alpha. Il y a d'autres références qui sont mises pour filtration, absorption exclusive des endotoxines. Ça, leur AMM, c'est pour les chocs septiques endotoxiniques. Et il y a des filtres assimilés à ce qui est utilisé dans la dialyse hépatique, MARS. Donc, il y a 3 types de filtres. Et il y a un autre type qu'on utilise, de technique absorptive toujours, mais utilisée pour les hémodialysés chroniques par intermittence. Donc, le malade il est dialysé conventionnellement et une fois par semaine ou une fois par 15 jours, on met une séance avec absorption pour éliminer les moyennes molécules au-delà de la bêta de microglobules. Donc, c'est ça le…
de comparaison entre les différentes techniques
pour la Covid, ce qui est utilisé, c'est le 380. C'est pour les cytokines. En tout cas, c'était très, très, très enrichissant, surtout avec la présence de 2 éminents intensivistes avec nous, professeur Ktani et professeur Adib. Donc, vous avez enrichi le débat. Et qu'on soit néphrologue seul entre nous, ça n'a aucun sens en 2021. Donc, pour parler de ACAI in Intensive Care Unit, ça n'a aucun sens. Ce n'est pas le travail de néphrologue ou du réanimateur, c'est de tout le monde. Et merci pour votre présence avec nous. Merci, professeur Jbran. Merci, professeur Tiwi. Merci, professeur Ktani. Merci, professeur Adib. Vous avez enrichi le débat. Et j'espère que ça va continuer en présentiel la prochaine fois.
Inch'Allah.
Merci pour avoir réuni tout ce monde. J'espère qu'on aura le temps de se réunir et de parler sur les perspectives d'avenir concernant ces thérapies.
Merci. Alors, je veux dire un mot pour Jafran. J'ai l'impression que cette société peut faire une différence parce qu'ils sont investis par rapport à la formation et beaucoup de choses. Et je pense que c'est l'un des gros manques qu'on a par rapport à nos autres collaborateurs. Donc, comme a dit Oustadi El-Kitani, cet aspect formation de façon régulière, en accent sur le personnel paramédical, est quelque chose de marquant dans nos unités de soins intensifs.
Oui, en fait, bien sûr, parce que nous, Jeff From, nous avons une plateforme qui est 100% pour les formations. Et c'est concernant la technologie et aussi concernant la formation, les opérations. Ça veut dire que chaque semaine, nous avons des formations sur le webinaire. Donc, je pense que ce sera très important et très intéressant pour vous et votre collègue. Parce que franchement, pour les nouvelles technologies, je pense que la formation, les opérations, ça c'est très, très important. Oui. Donc, oui, merci.
Merci.
Oui.
Merci.
Merci, oui, merci, professeur Omar. Je pense, ça fait plaisir de faire le premier webinaire avec vous et aussi j'espère qu'on pourra continuer notre réunion pour la prochaine, Inch'Allah. Oui.
Inch'Allah.
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 Merci. OK.
Merci tout le monde.
OK, merci, merci, au revoir.